My name is Dr. Tendai Manyeza. I'm the medical officer at Old Mutare Hospital, the medical superintendent. Old Mutare Hospital is an old hospital built in around 1912. When it was started by missionaries from Germany. A lady from Germany, she's the one who started a small clinic just close by. And the clinic later on developed into the current structure over the years. The hospital is a 70-bed hospital manned by 1 doctor, 13 nurses, 13, and about 25 support staff. We see on average about 50 to 60 patients a day in our outpatients. And our bed capacity, I said it's a 70-bed hospital, but generally it's about 70 to 80% full, the hospital. The busiest units mainly at the hospital are the outpatients and maternity. In maternity, we deliver about between 30 and 40 babies a month. The hospital does not have, it only caters for medical conditions in terms of managing them. We don't do any operative surgery as yet. We are still trying to equip our operating room so that I'm able to do some operative deliveries or even operations. So what it means is for the cases that needs operation, I do the initial management and then I transfer them to the provincial hospital for the operations themselves. This then means our transfer rate is a bit on the high side than what it should be. Besides the hospital, besides offering the outpatient services and the maternity services, we also have got HIV/AIDS activities. And in HIV/AIDS, we've gotten the voluntary counseling and testing center. We also offer antiretroviral treatment to our patients. We've got prevention of mother-to-child transmission, orphans and vulnerable children, home-based care and support groups, and behavior change activities. Some of them, those services, we offer them as community-based, while the others, they are hospital-based, especially the antiretroviral and the prevention of mother-to-child transmission and services. Besides that, we've got X-ray services, laboratory services, dental services, pharmacy services. These services, they are very critical. You see that I've mentioned this. They are very critical in any hospital where there is, if a hospital is to be rated as a hospital offering basic medical services, these services have to be there. However, the challenge we have with these services, one, these units are not well equipped. Number two, they are not well staffed. We don't have the qualified personnel to run this. So what we've done to go around that problem is to train some of our junior staff to go for, at the provincial hospital, so that they are able to offer some form of services, so that at least we have X-rays done, for example, dental extractions of teeth, and even the laboratory. And you find that my passion is to get the operating room functioning, to have the X-ray well functioning, the laboratory, the dental unit, because these are key services, and even the pharmacy. They are key services which can boost the hospital income. Several times we get donations in terms that will help us support our own services, but we have to have put in place rather a system which will ensure self-sustainability, especially in terms of the financial resources. So these services, when well catered for in terms of staffing and equipping, I think will meet this objective. Our challenges, besides what I've just said, one, the infrastructure is now very old. So what we intend to do in terms of getting it to basic reasonable services is to revitalize the current or renovate the current facilities so that they're at least presentable. And this involves doing some basic painting, basic maintenance services, because over the years, because of the economic situation, we'd sort of neglected this, so to say. But now I think we are forced by circumstances to make sure that we have to make sure that our hospital is up to date. Besides renovating or revitalizing the current structure, we think, would love to have new units at the hospital. We've got one male ward. We think we should have 2 male wards, one for surgical and one medical. And we've got one female ward. We should have one medical and one surgical. A very small pediatric ward we have, and we should have a fairly big pediatric ward, because we see so many children with various ailments. So as we equip and get our operating functional, we should now we are now starting to think about having all these other units. Our pharmacy unit is now very old. Some of you might have seen it. It's really very old. We now need a new pharmacy, a new outpatient department, new wards, a new maternal and child health unit, and our vehicles are now very, very old too. So they need, we now need replacement in those areas. You were asking about the revitalization program that we were involved in with Dr. Cherry and Thomas. We were one of the lucky ones. I count myself very lucky, because we benefit from that program. We benefited from a generator. The hospital now has a backup generator. In situations of power cuts, the generator just starts, and then it doesn't disturb our services. So we benefited from that perspective. We benefited from a hospital vehicle, which was an outreach vehicle. This was in 2001, 2002. We've done our best to try and keep it roadworthy, but you find that now it's now very old, and repair costs are now on the very high side. So that's one area, especially when we are talking about our community-based services. We also benefited from computers. He bought a computer for the hospital. So those are some of the things that we benefited from as we started the hospital revitalization. Later on, then we were sending money for buying equipment, buying linen, and doing some basic maintenance in the hospital. If you look at the current infrastructure, it's quite a lot needs to be done to get it going. And in 2011, we had a team from the USA led by Julie Warren, and when they went back, they set up the old Mutare hospital connection, and Julie Warren is coordinating with the partners in the USA. They came in 2011, they looked at the infrastructure, appreciated the problems on the ground, and one of the things that big assignments that they left me with was to try and get a master plan of the hospital. Was looking at our infrastructure here, the buildings are so spaced around, so the idea is to get a master plan and project future developments on that master plan. And the idea now is to make sure that we build our buildings very close together so that they are not as well spaced as they are. Our vision is to have a comprehensive unit that is offering basic services or comprehensive services to our communities. And when we say comprehensive services, it means our patients should be able to get all the services around without having to be referred elsewhere, and at low cost. While of course we are rated a rural hospital, and our patients pay very minimal fees, we intend to recover some costs from that, so that at least the system or the service will continue to give those services to our patients. That's what I can say for now, unless there are questions. Our maternity unit, which is very overcrowded. We carry out the antenatal follow-ups, the under-5s clinics, even the deliveries are done in this unit. So this unit is now very congested. And our maternity and under-5s or maternal child health services are done 24 hours a day, 7 days a week. So it's almost always overcrowded. The ideal would be to have this unit left for delivery services and then have a separate maternal child health unit where the postnatal and antenatal follow-ups are done. I'm told they've got about between 70 and 80 children in the home right now. Before we moved over into these homes, we used to look after them at the hospital in sort of dormitory lifestyle. So until somebody brought up this idea of keeping children in the homes, and that's when we got donations from FOSA, which is an organization in the USA that supports the home. And also the General Board of Global Ministries, they also support the home with a grant. So we are the idea was here we've got a primary school, a high school, and we have a university close by. Why still continue with what we used to do in the past, whereby we would look after children from birth to about 5 years. After 5 years, they are transferred to another home elsewhere. And we noted that for the children, that relocation was sort of traumatic to some of them, especially if they developed attachment to this place. So we are actually reaping the benefits of keeping them in the homes. We have a few of the children right now having completed their high school. Some of them have joined colleges, and all those children, as they go out to their various places of education, they've developed this special attachment to this place. The idea, of course, is we would not keep all the children indefinitely. The idea is to, at about 18 or so years, to get some of the children out of the home. But as they graduate, the idea was to equip them. For those that are able to make it academically, we let them proceed through whatever sponsorship. For those that are not gifted academically, we would then make them join vocational training colleges so that they are sort of self-equipped. I mean, they are equipped with some training of some sort that will make them lead a life of their own independently as they leave the home.